Injuries in volleyball are commonly due to jumping and landing as well as from hitting and blocking the ball. The ball can reach speeds of 80 miles per hour and can cause significant injury should the ball strike an unintended area of a player's body. Certain positions are associated with specific injuries, XX table. More injuries occur during hitting and blocking than during passing or setting. Most injuries, whether acute or overuse in nature, occur during the act of jumping. Overuse injuries are somewhat more common than acute injuries and are due to faulty technique, amount of repetition, or type of playing surface. Elite athletes are at greater risk of overuse injuries, presumably due to more hours of practice. Ankle-foot injuries. Ankle sprains. Ankle sprains are the most common acute injury in volleyball, with one study showing these accounted for 41% of all volleyball-related injuries. These usually occur when landing onto another player's foot, often a player from the opposing team, so these are more common in positions that play around the net. When evaluating a sprained ankle in a volleyball player, there is usually evidence of injury to the lateral ankle with swelling and tenderness. It is important to not miss a fracture, as the treatment would be likely different. Achilles tendinopathy. The paratendon of the Achilles tendon may become inflamed 2 to 6 cm above the calcaneal attachment site, called Achilles tendinitis. This is common in sports like volleyball where there are repetitive eccentric loads to the Achilles tendon from jumping and landing. There is tenderness and sometimes crepitus of the tendon. Initial treatment consists of rest from painful activities, ice, and anti-inflammatory medication. Rehabilitation consists of stretching, progressive strengthening, and gradual return to activities. Knee injuries. Patella tendinopathy. Explosive and repetitive jumping is important to success in volleyball and can lead to pain in the patella tendon. An estimated 40% to 50% of high-level volleyball players develop patella tendinitis at some point. Risk factors for patella tendinitis in non-light athletes are male sex, higher body weight, and taller stature. The most common site of pain is where the patella tendon attaches to the inferior pole of the patella. There is point tenderness at this site that distinguishes it from patellofemoral syndrome, another common source of anterior knee pain in athletes. Treatment is similar as described for Achilles tendinitis. Anterior cruciate ligament injury. Anterior cruciate ligament tears are not as common as patella tendinitis but are a much more serious injury. It is well recognized that they occur at a considerably higher rate in women than men in landing and cutting sports. In addition to female gender and prior ACL tear, a number of risk factors have been proposed including intercondylar notch width, generalized ligamentous laxity, and increased body mass index. In volleyball, the mechanism for ACL tear usually is coming down awkwardly from a jump or a cutting maneuver. The athlete is almost always unable to continue playing after sustaining this injury. Swelling typically develops within a couple of hours. Shoulder injuries. Shoulder instability. The arm swing during a volleyball overhead serve and spike traditionally has been thought of to occur in 3 phases: cocking, acceleration, and deceleration follow-through. To forcefully hit an unreturnable ball to the opponent's side of the court, the hitter's arm goes into an extreme external rotation and extended position during the late cocking early acceleration phase. This position levers the humeral head anteriorly on the glenoid and may result in pain and/or a feeling of shoulder instability. The function of the rotator cuff is to restrain excessive movement of humeral head and also assist in internally and externally rotating the humerus. The most common cause of shoulder pain in volleyball players is overuse of the rotator cuff, which is understandable given the typical volleyball hitter-server hits the ball thousands of times in a typical season. Shoulder pain also may be due to a variety of other pathologies such as tearing of the inferior glenohumeral ligament or the labrum. Treatment involves strengthening of the rotator cuff, which limits the amount of anterior subluxation of the humeral head and provides endurance. Hitters and servers who have a long history of repetitively placing their shoulders in extreme external rotation may develop where there is limited internal rotation of the shoulder compared with their non-dominant side, a condition known as glenohumeral internal rotational deficit. This is due to contracture of the posterior capsule of the joint and may result in obligatory posterior-superior shift in the humeral head during the cocking position, which is associated with a variety of painful shoulder conditions such as internal impingement, external impingement, and labral tears. If symptomatic, treatment involves stretches of the posterior capsule using sleeper stretches. Hand-wrist injuries. Traumatic injuries to the fingers are common in any ball handling sport, and volleyball is no exception. Blockers are especially vulnerable to injury from axial loads to the fingertip and hyperextension of the finger from the ball. Hitters can get finger injuries if they hit the net or another player during the follow-through phase of the swing. Radiographs are warranted for most finger injuries to rule out fracture or dislocation. Most finger injuries involve ligamentous injury to the proximal interphalangeal joints of the fingers. Low back pain. Underhand passers are susceptible to low back pain due to repetitive lumbar flexion. The upper extremities held in front of the body act as a long lever arm, placing considerable strain on the low back. Passers also are susceptible to low back pain when they must repetitively rotate at the trunk to accept high-velocity jump serves from the side, when they do not have enough time to get in front of the ball.